So thank you for the introduction and thanks for the invitation as well. It's a real pleasure for me to be here with you. And so in the next 20 minutes or so, I will do a brief overview of PPGL. And I know that in the next minutes, you will have expert on surgery, imaging, and diagnosis. So let's start. So if we start from the beginning, so I will talk about the pheochromocytoma that is originating from the adrenal gland, the center part, the medulla. And I will use paragangliomas for the tumor that are outside the adrenal gland. So we can find PGL from the skull base to the pelvis. And during my talk, I will use PPGL to speak about pheochromocytoma and paragangliomas. So as you know, this is a very rare disease with an incidence less than 1% over 300,000 diagnoses per year. And PPGL may cause hypersecretion of catecholamine. So if we talk about the presentation, it's the classic symptoms that we see in clinic and that are reported in the literature. It's headaches, palpitations, hyperhidrosis, pallor, tremor. And we have also patients that have, of course, in patients with secreting tumor, high blood pressure. But I just want to underline that it's not all field that lead to hypertension, because often people in the medical person and thinks, oh, if there is no hypertension, there is no field. But this is not true. Up to 10% of field may not have high blood pressure. So this is good to know. And finally, we have a lot of symptoms that may be presenting symptoms for the disease, for example, nausea, vomiting. And in the next slide, I will show you a case that we reported a few years ago. So it's a 64-year-old male that had a severe anxiety, and he had a follow-up for 13 years for a panic attack, and he was not able to be controlled under medication. And finally, he had a CT scan for another reason, and a big pheochromocytoma was found. It was the size of 24 centimeters, associated with very high level of catecholamine, as you see on the table here, and with norepinephrine and dopamine and epinephrine as well. So this patient undergone the surgery, and after the resection, it was much better regarding the anxiety. So the panic attacks were gone and improved a lot to get a more normal life. So another unusual presentation of PPGL, secreting PPGL, it's what we call a Takotsubo-like cardiomyopathy. It's a little bit like a heart attack, I can say, it may give heart pain. And we found that it was relatively frequent in our cohort of patients. So at that time, we reported about 3%, but now it's about 6% of presentation. And other team reported the same thing in their cohort as well. So this is another presentation, and it's not rare. It may happen that it's the initial presentation of the disease, or sometimes we see patients that had in the past 2-3 episodes of Takotsubo before that people think about the diagnosis of PPGL. So this is the outline that we will discuss. I will go, it will be really an overview. So, and you will discuss each point more specifically with the next speakers. So regarding the biochemistry, so what the guidelines say is for the diagnosis of PPGL, so we can use urine, 24-hour urine collection, or we can use the plasma metanephrine level for the diagnosis of secreting PPGL. So we have to remember that the cutoff is dependent in part of the age of the patients. So in our hospital, we report the normal levels, and it's based on the age of the patient. So with more we increase in age, more the upper limit of the normetanephrine is increased. So this is good to know. And also we have always to keep in mind that we may have false results associated with medication. So this is the list of medication that may interfere with the measure of normetanephrine. So one key message that we teach to our students is we should always start with biochemistry, and then if we find something, if it's positive, then we go to imaging. In the true life, it's not always like that, because one classic way is the patient go to the emergency room for an adrenal pain, and he has a CT scan, and then a mass is found in the adrenal gland, and then we go in the other way, it's imaging first and the biochemistry after. Yeah, you have a question?
I just wanted to know if these slides will be made available afterwards.
Yes.
Yes, okay, great. So perfect.
So I know that will discuss more deeply about imaging, but the first test that we have to do is the CT scan. So with the CT scan, we can identify if there is an adrenal mass or not. If it's negative, then we go outside the adrenal gland and we will do an imaging of the thorax and the abdomen. So one important part is the radionuclide imaging of PPGL, as you know. So we can use MIBG, FDG PET-CT, F-DOPA PET-CT, and 68 gallium DOTA PET-CT as well. Here in Quebec, we don't have access to F-DOPA, so we use FDG PET and gallium 68 DOTA PET. So there's two goals with this imaging. So it may be useful to characterize a mass, to do the staging of the disease, and also to determine if patients may be eligible for treatment, especially for MIBG and dotatate. So this is an example of a patient with a Pheochromocytoma. So on your left, this is a CT scan. So you see with the arrow the mass, and there was an uptake at the FDG PET-CT and also at the gallium 68 dotatate. So regarding the mutation, the gene mutation, the genetics, I just want to remember you that we will talk about germline mutation and somatic mutation. So germline mutations are present in all cells. So we will have it in the blood of the patient, in the DNA blood. And these mutations are inheritable, so for the family members. And when we talk about somatic mutation, it's mutations within the tumor itself. So it's what we call sporadic or and they are non-heritable. So today I will just speak about germline mutations, so inheritable mutations. So as you know, PPGL is clearly genetic disease with more than 20 susceptible genes that were described so far. And we know that these mutations, the presence of this mutation is very frequent in PPGL. So here is a complicated schema with a different pathway, but just briefly, so we can divide the genes in two main clusters. Cluster 1 that is related to the Krebs cycle, cluster 2 with the kinase signaling, and cluster 3 with the Wnt beta-catenin signaling. So what is the risk of carrying a germline susceptibility gene mutation in patients with PPGL? So I'm sure that you all know the answer. So it's about the 30%. So depending which cohort we look, if the cohort include family members as well, so it may increase up to 40%. And this is the latest guidelines from the American Society. So since 2014, the recommendation is to offer genetic counseling to all patients with PPGL, as you know. So it's what we do here in Quebec at CHUM. And we also offer the genetic counseling in patients that were operated several years ago, so when they are interested to do the analysis. So we use a multi-gene panel. Here in Montreal, we send our sample to Invité in US. And now they have a multiple gene panel of 19 genes. So here in the province of Quebec, we started to do genetics back in 2005. So we offer to our patients, we were doing a collaboration with Anne-Paul Jimenez Roquepot de Paris. And she was, in this collaboration, she was offering the genetic testing in our patients. So back in 2005, it was not a multi-gene panel. It was one gene at the time, and depending on the presentation, so we were choosing which genes we will test, and then if it was negative, we were moving on to the next genes. And at that time, there were no 20 genes, so it was 6 or 7 genes at that time. And from 2015 to now, we are using the multi-gene panel. So what we have in our cohort here in Quebec, it's a prevalence of 26.2% of patients are carrying a germline mutation. So this is pretty similar across the world. And these mutations are more prevalent in young patients, as expected, and in patients with metastatic disease as well. So what is the particularity here in Montreal is we have a lot of patients carrying a SDHC mutation, which is rare across the globe. And the reason for that, it's always the same mutation. So it's what we call the founder mutation. So we have a very particular genetic background here in Quebec with French Canadian patients. And so we think that this mutation was introduced back in the 17th century from a colon and that was coming from France to Nouvelle-France here, and the mutation was descent for the descent of these patients. So all genes that are related to PPGL, they have what we call an autosomal dominant transmission. So what that means is that we have one chance to 50% of chance to transmit the mutation. So this is a lot, and as you know, there's a lot of impact for family members. So it's for that also for the patient, but also for the family to identify these mutations. The treatment of choice for PPGM is also always first to perform the surgery when it's possible. And so I just want to highlight the fact that we have to prepare patients before to go to the surgery. So patients with secreting tumors, so all patients with Pheochromocytoma, and patients with secreting PGL as well. And sometimes I prepare also patients with the non-secreting PGL. So not for head and neck, but for thorax and abdomen, I prepare them as well. Because it may have a secretion, but that we are not able to detect with our tests currently. So I prefer to cover them during the surgery. So the goal is to give medication to control blood pressure. And the goal also is to avoid peaks of hypertension during the surgery. So for patients that we are not able to have a surgery, or in patients for metastatic disease, I know you will have a talk on this, the specific treatments, but just the general, in general, what we have to know is these treatments will be based on the evolution of the disease. So based on the growth rate, so a slow growth rate will be addressed differently than faster growing rate, and also on the tumor burden of the patient. So several options: active surveillance, local therapies, PRT, TKI, and chemotherapy, as you know. And we have to discuss in team these approaches to have the best treatment for our patient. So all this genetics story now lead to a personalized management of patients with PPGL. We have few examples now that are seen in clinic. So for example, a patient that has a mutation in the red gene, the HL genes, and probably NF1 genes, we can offer a subtotal adrenalectomy. So this is important for patients with bilateral pheochromocytoma. So this may avoid with delay adrenal insufficiency for the future for them. So this is very important. So most of the time, when it's possible and when we suspect VHL or red mutation or NF1, we try to have the results of the genetic analysis before the surgery in order to guide the surgeon. If it's possible to do a partial adrenalectomy, we will consider it for patients. Also, you recognize the three clusters that we discussed earlier. So with the hypoxia cluster 1, kinase signaling, and Wnt signaling. So what is interesting is depending on the mutations and the cluster, we know that we can target more specifically the treatment for the patients. So for example, we can use tyrosine kinase inhibitor, for example, in cluster 2. So this changed the approach, and it's in consideration now in clinic. Also, as you know, we have now guidelines specific for ASDHB patients, guidelines specific for ASDHD patients, because although it's the same diagnosis, the evolution is very different and the approach is different as well. So I think this is a very new example of personalized medicine for PPGL patients, depending on the genetic status. So one important question is the surveillance. So we know that all patients that have the surgery for PPGL should have a lifelong surveillance. And I think it's still debated what is the best approach, but at least biochemical testing once a year. And this slide shows the family identification of genetic testing. So we were doing it since several years. We get results for the patients, results for the family members, but the question was, do we have gain to do that? Because it costs a lot, the imaging, and it creates a lot of anxiety for patients as well. So we have to do that, but here there was a new recommendation in 2021. So all patients with a mutation should have an initial screening for the presence of PPGL. And more recently, there's data that, yes, it's good to do that, and we can improve outcome of patients affected by PPGL in family members. So this is very reassuring that we're doing the good thing, and we have to move forward and to keep going with this family genetic screening for most mutations. So, but for example, there's more question about ASDHA mutation, for example. So during this symposium, it was discussed that probably not all patients with ASDHA mutation asymptomatic carriers that I'm talking about should have this protocol. But for most of the patients, this is a good protocol that we should apply in families. So in conclusion, germline mutations are found in up to 30% of patients with PPGL. And the early identification of genetic mutation can help the patient and give information about disease course, may guide the management, and certainly help the families. And I just want to underline that the management of patients with PPGL, it's a team management. So here at CHUM, we work as a multidisciplinary adrenal cancer team. So we were recognized by the Quebec Ministry as a reference center for patients with adrenal tumors. And we have several physicians. We are working together, but also we have biochemists involved, a nurse, the geneticist, nutritionist, psychologist, social worker. So everybody is important in this team to take care of the patient. And we have also a variety of translational research, as it was mentioned at the beginning. So patients have the opportunity, if they agree, to participate to biobanking of tissue and blood, and we study these samples in my lab, and the objective is to find new findings and to go back in the clinic and to improve the outcomes of patients. So thank you for your attention, and thanks again for the invitation.